Oh, good evening. No, sorry, good morning, everybody. So uh, I, Takumi and Nora and Yousef, I'm going to presentation. Today's case is case 35, 2090. A 66-year-old man with pancytopenia and rash, co-selected by Dr. Pacheco. Today's date is March 23rd, 2021. Next slide, please. Uh, can you go to second slide?
Nora, can you proceed?
Second slide. I see it now.
Yeah,
Okay.
I can do it. So outline is a chief complaint and onset, medical history, family history, social history, physical exam, labs, diagnosis process, pathology, treatment. So next slide, please. Chief complaint and onset. Chief complaint is on admission to this hospital, the patient record ongoing swelling the legs or arms and periovital area, along with decreased appetite and poor oral intake. And onset is a diagnosis of pancytopenia was retrieved 2 years ago. So I will continue explain about medical history. He has a history of coronary artery disease, hypertension, hyperlipidemia, hypothyroidism, and gastroesophageal reflux disease. And he has a medication now, pantoprazole, etrixosin, lisinopril, metoprolol, aspirin, amoxicillin, and simvastatin. Amoxicillin causes nausea and simvastatin causes myalgia. And 1 year ago, admission he had a fever, ongoing swelling in the legs, forearm, and periovital area, decreased appetite, and poor oral intake. And 3 months before admission, he had a fever. Temperature is 38.3 degree and shaking chills, scattered pulses have developed in his arm and leg with no associated pruritus. I continue medical history. So 2 months before admission, he had episode of orthostatic hypotension and dizziness. On 2 occasions, the patient was admitted for right tenderness. Magnetic resonance radiogenocephalography showed a small amount of perichorectic fluid and middle edema in the right paracorac infiltrative process. And 8 days ago, admission orthostatic hypotension recurred. He was pale, appetite ill, and had marked edema of the legs and pelvic region. Scattered mammal and erosion region with overlying scar were noted on both feet, both forearms, and the medical right thigh. Petechiae were also seen on arms and chest. The remainder of the examination was normal. So,
When we take at the family and social history, we see a single 66-year-old man living in a rural area of New England. He worked in healthcare before retiring several years ago. And this patient does not drink alcohol or use any illicit drugs, but he does smoke 3 cigars a day. He had a father that died from coronary artery disease, and his brother had sarcoidosis and alpha 1 antitrypsin deficiency. He also had an aunt and uncle that had cancer, but the types were unknown. So on the physical exam, his temperature was 36.4 degrees Celsius, pulse was 93 beats per minute. Blood pressure was 119 over 74. Respiratory rate was 16 breaths per minute. Oxygen saturation was 97% on ambient air. Weight 78.6 kilograms. And the patient appeared frail. Abdomen was soft with no tenderness or organomegaly. The remainder of the examination was normal. So when you take a look at the labs, the labs all appeared normal. Hemoglobin was normal. Hematocrit was normal. MCV and white blood cell count was normal. Platelets were also normal. There's a bone marrow biopsy that was consistent with hemophagocytic histocytosis. And the aspirate revealed maturing trilineage hematopoiesis and mildly hypercellular marrow with many histocytes and numerous engulfed erythroid elements in the cytoplasm. Peripheral blood smear shows presence of Burr cells and schistocytes. So the immunohistochemical examination revealed many scattered T cells and occasional B cells, elevated ALT and AST levels. Nucleic acid testing of the blood for Epstein-Barr virus DNA was positive. FDG tracer revealed insignificant homogeneous FDG uptake in the spleen. And Congo red staining for amyloid was negative. Serum protein electrophoresis was normal. So we have here 3 panels. At panel A, we have the hematoxylin and eosin staining of a core biopsy specimen. And you can see numerous histocytes with engulfed erythroid elements in panel B and mature red cells in panel C. And you also see immunohistochemical staining for CD163. So that shows the histocytes filled with intracytoplasmic red cells in panel D. So a skin biopsy specimen obtained at this hospital from the medial left thigh showed an atypical proliferation of medium to large pleomorphic cells in the dermis and subcutaneous tissue that was associated with prominent KRXs in panel A. Mild interface changes of the epidermis with ulceration were also identified. The infiltrate was angiocentric and angiodestructive, which can be seen in panel C. Immunohistochemical stains showed that neoplastic cells were CD31 and CD21 T cells. The lymphocytes expressed CD56 as well as cytotoxic proteins, granzyme B and perforin.
Okay, so next I'm going to discuss the diagnostic process, the pathology, and treatment. There are very few hematologic cancers that can cause hemophagocytic lymphohistiocytosis. And there are approximately 10 to 35% of patients with non-Hodgkin's lymphoma that would present with extranodal diseases. And these diseases can occur in testes, bone, kidney, skin, GI tract, and central nervous system. And as seen in this patient, the extranodal disease occurred in the skin. And the physicians narrowed down the diagnosis to T-cell lymphoma because T-cell lymphoma gives rise to extranodal diseases, and it is also capable of triggering HLH, which is hemophagocytic lymphohistiocytosis. And there are multiple subtypes of T-cell lymphoma. However, the physicians were supposed to narrow this down into one particular subtype of T-cell lymphoma. First, the initial diagnosis was extranodal NK T-cell lymphoma of nasal type, and this was considered because this particular type of T-cell lymphoma is EBV associated, and the T-cells in this particular patient expressed CD56 but lacked CD8. So that was the reason why they initially diagnosed with extranodal NK T-cell lymphoma. However, the patient didn't have any nasal masses, and the FDG uptake was insignificant in this patient. And with this particular subtype of lymphoma, FDG avidity is high. So that was why this subtype was ruled out. However, at the end of the day, due to the scaling erythematous rashes and the fact that there was HLH symptoms, they narrowed it down to primary cutaneous gamma delta T-cell lymphoma. And this is because in a series of 20 patients with confirmed primary cutaneous gamma delta T-cell lymphoma, 70% will present with hemophagocytic lymphohistiocytosis symptoms. You can see here, although this is not the particular presentation that was given on, like the rashes were not shown on the case study, but this is just an example of what the lesions could look like. And at the end of the day, given the combination of the patient's HLH symptoms, the laboratory findings, the absence of lymphadenopathy, and the presence of the cutaneous lesions, the diagnosis of primary cutaneous gamma delta T-cell lymphoma manifesting with HLH symptoms was favored. The pathology of this disease, that's how the lymphoma ended up giving rise to HLH symptoms, is explained here. So normally what happens in the immunologic synapse is that after T-cell is activated, the T-cells would usually release perforins and granzymes that would result in lysis of the antigen-presenting cells. However, when there are certain disorders such as chronic antigen exposure, Epstein-Barr virus infection, or B anti-cell cancers, the certain genetic alterations can cause sustained cytokine production and also cause inability of lysis of the antigen-presenting cells. Because of that, the macrophages will remain active, and due to the sustained cytokine production, it will cause the macrophages to phagocytose erythrocytes, red blood cells, and this will give rise to the hemophagocytic lymphohistiocytosis. So this is how T-cell lymphoma could possibly cause HLH symptoms. And it is summarized here with this picture, where normally you'd see the T-cell exocytosing certain perforin granules and granzyme granules to break down the antigen-presenting cells after they've been activated. But when there's presence of, let's say, chronic antigen exposure due to Epstein-Barr virus or certain cancers, the T cells will not be able to release these granzymes anymore. And also they have sustained cytokine production, which will cause the antigen-presenting cells to remain active. And because of this, after sustained activation of the antigen-presenting cells, they end up phagocytosing red blood cells, which will give rise to the hemophagocytic lymphohistiocytosis. And finally, the treatment for this patient was administered, and it was cyclophosphamide, doxorubicin, dexamethasone, and brentuximab vedotin regimen. However, although in 4 days, the chemotherapy reduced the lesions, after a day, the patient began to experience progressive respiratory failure, and they first diagnosed that it could possibly be due to diffuse alveolar hemorrhage, but then bronchoscopy came back negative. At the end of the day, after consultation with the patient's brother and sister-in-law, they decided to initiate comfort measures so that the patient can die peacefully at hospital day 57. After the patient's death, familial HLH germline genetic analysis was taken, but the mutation, it was negative for mutations. However, targeted gene sequencing of the patient's skin biopsy specimen for hematologic cancers revealed a nonsense mutation in the NFAIP3 gene. So in summary, the physicians were presented with a 66-year-old man with pancytopenia and rash, and this was diagnosed as primary cutaneous gamma delta T cell lymphoma manifesting with HLH syndrome. This caused him to present with swelling of legs, forearms, and periorbital area. T cell lymphoma caused HLH syndrome due to sustained cytokine production and inability to lyse antigen-presenting cells. Chemotherapy was inefficient because this is a malignant lymphoma, and eventually the patient died peacefully after comfort measures were initiated. Here is our reference, and we'll take any questions now.
Thank you very much. I think I see already some questions from Florence Reynolds groups. I think it's group number 5. So question is asking, what are the main side effects of cyclophosphamide?
The main side effect of cyclophosphamide is hemolytic uremic syndrome.
Hemolytic uremic syndrome. So, but don't forget, guys, that cyclophosphamide also may cause severe hemorrhagic cystitis. So, and cause actually bleedings from the bladder. So that's what we study actually when we discuss with you diseases of the urinary system and with bladder, and when we talk about male-female reproductive system. So remember, cyclophosphamide causing bleeding from the bladder, or we call hemorrhagic cystitis. Now that's one of the main effects. So now next question comes from group 4. Let me mark group 4. Does this specific lymphoma always present with rash? Good question. What do you think, guys? Who would like to answer on this question in your team?
I can answer. According to the case study, they said that most of this particular primary cutaneous lymphoma would usually present with erythematous scaly rash. So it is very likely.
All right, very good. Very good. So Yon Wu, I think it's team 1, if I'm not mistaken, asking question, why brentuximab vedotin administered rather than vincristine, please, in details, please. So who was talking about treatment, please?
I spoke on treatment, and brentuximab usually would bind to CD30 receptor, and I can show here. And the specific reason why this was chosen was because of the superiority of this regimen in peripheral T-cell lymphoma expressing CD30. This particular lymphoma had CD30 expression. So that's why they used this in brentuximab instead of vincristine.
Mm-hmm. Thank you very much. And I see one more question from group 3. Is there any specific findings in the labs that can point to this diagnosis? So can you tell me based on what findings, right, the diagnosis of lymphoma, right, and with histiocytosis was provided to the patient?
Yes, in the labs, you can see that the patient has severe...
Can you guys present the labs values so we can take a look at them?
Sure. So you can see in the labs that the patient has severe anemia. The hemoglobin, hematocrit levels are low.
I don't see labs of anemia.
Can you Can you go
Oh,
up? Yeah.
wonderful. Thank you.
Sorry.
Thank you so much. Great. All right.
Yeah.
Please go on.
Yeah, so you can see that the hemoglobin and hematocrit levels are low. MCV is normal, but the white blood cell count is also very, very low, as well as the platelet count. And you can see in the bone marrow biopsy as well that it was consistent with the hemophagocytic histiocytosis.
Mhm. So diagnosis was done based on bone marrow biopsy, right? As far as I
Right.
understand. All right. By the way, what you said it's a lymphoma, right? What kind of lymphoma is this? It's T lymphoma, right? Or B lymphoma?
T lymphoma.
T lymphoma.
Lymphoma. How you decide, or how doctors decided that this is T cell lymphoma? Based on what? Analysis of what? Or based on what kind of stainings, or how we figure out that this is indeed T lymphoma, not B?
The immunohistochemical stainings for CD.
Chemical stainings for which markers? Yes. Can you clarify for me, please?
Yeah, it will be between CD1 to CD9.
CD1.
Between those.
Can you show me these results in your labs? So because it's, I think, what answering also question to confirm diagnosis. Is there anywhere where you mentioned this? CD3 and CD2 T cells. Okay, very good. Wonderful, wonderful. So, and excellent. And what going back to the anemia labs, what the slide number 8. So, my question to Takumi. Takumi, what kind of anemia is this? Well, let's say if you look at this kind of results, what kind of type of anemia you can say this patient has?
What?
What type
Anemia.
of anemia? Yeah. Remember, there are many types of anemia exist. Microcytic, macrocytic, normochromic, hypochromic, hyperchromic.
I
So
think
which one is this
chronic disease.
anemia of chronic disease?
Yes, I think, yeah.
Why you decided that this is anemia of chronic disease?
Because I think WBC, no. WBC is low.
But
And
in anemia
cancer,
chronic disease, WBC is usually normal. It's
yes,
actually
cancer, I
elevated
think.
because it's usually inflammation, so white blood cell
And,
count elevated.
and I think his age also related to cancer.
Mhm. So you think it's a cancer caused this anemia? Okay, gotcha. So the tumor, right, lymphoma caused this anemia. All right, and in such case, my last question: what type of anemia is this? Normocytic, macrocytic, or microcytic anemia? Well, maybe Yousef can help. What type of anemia are we dealing on this based on the lab values on slide number 8? So, is it normocytic, macrocytic, or microcytic anemia?
You ask me?
No, I'm asking entire team. And of course, first of all, Takumi, but after that, anybody from
No,
the team.
normocytic.
Normocytic anemia. Very good, very good. Absolutely right. So, and the last question, when you look at these lab values here, why do you think, Nora, this patient has such a low platelet count?
I think it's due to just the fact that the patient has this lymphoma,
Mm-hmm.
pancytopenia, and we also saw with initially the patient also had the petechiae lesions. I think it was shown in the medical history. Yeah, the petechiae was also seen. So
So you're saying petechia causing low level of platelets?
no, sorry, the low level of platelets gave rise to the petechiae, but the low
So you.
platelet level is
Mhm.
probably due to the lymphoma present.
So
I
what,
don't,
indeed, absolutely right. So what happened is bone marrow occupied by lymphoma cells, right?
mm,
And as a result of this, megakaryocytes and erythroblasts don't have any place to proliferate. So how we call this type of anemias when tumor cells occupying bone marrow and kicking out all other types of the cells from the bone marrow? Any ideas? How you call anemias which develops, let's say, when, let's say, some kind of tumor or cancer, right, infiltrating bone marrow and destroy bone marrow. A result of this patient has a low level of hemoglobin, hematocrit, low level of white blood cells, platelets. I can help you. It starts from letter M.
Myelodysplastic
All
syndrome.
right, no, not dysplastic, but very close. Myelophthisic anemia. Myelophthisic anemia. Very good, guys. Good job. All right, wonderful. So, thank you for questions, guys. I see also.
Actually, we have one more question actually from
Sure, please go
Samantha.
on.
She said she's asking, were the ferritin levels measured? Yes, they were. I'm not sure if we included them in the slides, but the patient exhibits hyperferritinemia, uh, and that's one of the key elements that were considered with making the diagnosis.
So why this patient has so much ferritin in the blood? So what is the reason for production of so much ferritin or accumulation of so much ferritin in this patient? So usually what ferritin accumulates in what conditions? If you guys started to answer this question, right? So what is ferritin and why is it, in what conditions it accumulates in high quantities in the blood, in the parts of the body, in the cells?
Usually in anemia of chronic disease.
In where?
Anemia of chronic disease.
Anemia of chronic disease. Very good. What about hemolytic anemias? Do we have ferritin accumulation or not?
No, you don't.
In general, ferritin, it's a kind of, what is the ferritin? It's what, this is a protein, right? What is the job of the ferritin? Is in our body.
To store iron.
Excellent. So, and what question is, in what conditions we have a lot of iron accumulating outside of the tissues? I can help you. It's something that we discussed in the liver diseases yesterday.
It could be lead poisoning.
Lead poisoning, it's sideroblastic situation, right? But again, it's usually lead, not iron accumulates. But iron may accumulate actually unprocessed as well. But what kind of conditions causing excessive iron accumulation in our body?
Hemochromatosis.
Hemochromatosis. Excellent. You see, guys. So hemochromatosis may cause, right? What else? What about hemolytic anemias? May they cause or not? Transfusion of red blood cells, right? So all this can cause excessive deposition of the iron. All right. So what question is? I'm just don't getting what you started with story of the ferritin. Why ferritin was high in this patient? So what I kind of not able to understand, or at least based on what Yousef explained me, I couldn't get it. So what was the reason for ferritin accumulation? Did this patient has hemosiderosis? Or why ferritin was high?
I don't know. I can't explain the exact mechanism behind that, but I mean we could check on that and get back to you. Yeah.
All right, guys. Well, again, remember, we not always get answers on what we want, right? So, but we always can look, right, and for right answers. So, and I think what indeed, maybe this patient had also on top of this lymphoma also hemochromatosis. Who knows, right? So, or maybe he has also some kind of hemolytic reaction. I don't know. So I haven't read through the article you guys were reading, so that's why when you raised this question about hemosiderin, so I said, okay, you probably know. Anyway, thank you very much. Nice job, guys. And the last team,